Welcome to this explainer. We're diving straight into congenital heart disease today. If you've ever wondered exactly how and why a developing heart can structurally deviate from its standard blueprint, well, you are absolutely in the right place. We're going to break down the anatomy, the risk factors, and some of the truly incredible medical interventions that are saving lives right now.
Here is our roadmap for today. We'll start with understanding congenital heart disease, move on to the causes and biological mechanisms, recognize the clinical signs, look at investigation and medical management, discuss complications and prognosis, and finally, wrap up with strategies for prevention. Let's get into it.
Section 1. Understanding congenital heart disease and the blueprint of the heart. Imagine the normal human heart as a perfectly constructed four-room house. You've got the right and left atria on top, and the right and left ventricles on the bottom. Blood flows through this house in a highly coordinated way, right? It's regulated by specific doors, the cardiac valves, and intricate plumbing, the major vessels like the aorta and pulmonary artery. Congenital heart disease, or CHD, is fundamentally a defect in that initial construction phase during fetal development. When the cardiac septa, valves, or those great vessels form abnormally, it completely disrupts circulation. We see blood shunting between chambers where it really shouldn't, physical obstructions to blood flow, or even the dangerous mixing of oxygenated and deoxygenated blood. To put this scale of this into perspective, consider this. CHD affects about 8 to 10 out of every 1,000 live births. That actually makes it the single most common congenital anomaly worldwide. And while advances in prenatal diagnosis and pediatric cardiology have dramatically improved survival rates across the globe, it's still a major challenge in developing regions, like Nigeria, for example, where delayed diagnosis and limited access to specialized cardiac care can severely complicate outcomes. Section 2. Causes and biological mechanisms. We're looking at genetics, the environment, and pathophysiology.
So, what actually causes this? When we look at the etiology of congenital heart disease, we find it is entirely multifactorial. It's a complex mix of genetic and environmental risk factors hitting during a really critical window of embryogenesis. On the genetic side of things, chromosomal abnormalities are a frequent culprit. Down syndrome, for instance, is commonly associated with atrioventricular septal defects. But the environment plays a massive role too. Maternal infections during pregnancy, like rubella, can directly disrupt fetal heart development. Then you have maternal health conditions, such as diabetes mellitus, elevating that risk. And, of course, exposure to certain environmental toxins, alcohol, or harmful drugs during pregnancy can interfere with normal cardiac formation, especially, when you combine that with a family history of the disease.
Now, there is a stark physiological contrast between the two main categories of CHD, acyanotic and cyanotic defects. In acyanotic defects, you have a left-to-right shunt, so oxygenated blood from the left side of the heart inappropriately flows back into the right side. Think of conditions like an atrial or ventricular septal defect or a patent ductus arteriosus. This basically overloads the lungs, increasing pulmonary blood flow and potentially leading to pulmonary hypertension over time. Then, on the flip side, we have cyanotic defects. These involve a right-to-left shunt or a physical obstruction to pulmonary blood flow. In this scenario, deoxygenated blood mixes straight into the systemic circulation. This means the body is actively being deprived of the oxygen it desperately needs to survive. To make this cyanotic category super concrete, let's look at the classic example, Tetralogy of Fallot. As the name tetra suggests, this condition features 4 specific structural errors happening all at once. First, a ventricular septal defect, which is a hole between the lower chambers. Second, pulmonary stenosis, or a narrowing of the valve leading to the lungs. Third, an overriding aorta that sits right above that septal defect. And fourth, right ventricular hypertrophy, basically a thickening of the right heart wall as it struggles to pump against the obstruction. These 4 errors working together literally allow deoxygenated blood to bypass the lungs entirely and escape directly into the body circulation. Moving on to Section 3, recognizing the clinical science. We'll cover symptoms and differential diagnosis. This brings us to a really crucial question. How does an invisible structural defect, completely hidden inside the chest, actually reveal itself clinically in a newborn or developing child? Some defects present literally right after birth, while others, well, they might remain totally undetected until later in childhood or even into adulthood. The clinical signs stack up quickly, and they all point back to that compromised plumbing we talked about earlier. General symptoms include shortness of breath, easy fatigability, and in infants you'll often see a noticeable pattern of poor feeding and a failure to thrive.
When we look specifically at cyanotic defects, the signs become highly visual. You'll see cyanosis. That's a bluish discoloration of the lips, fingers, and skin because of reduced oxygen saturation. Over time, chronic cyanosis can even lead to the clubbing or widening of the fingers. And here is a totally fascinating physical adaptation. Children with certain cyanotic defects might instinctively assume a squatting position during episodes of severe breathlessness. Squatting mechanically alters their blood pressure to temporarily improve oxygenation. Pretty amazing, right? On clinical examination, doctors will also listen for heart murmurs and check for tachycardia, a rapid heart rate, which indicates the heart is working way overtime. But hey, not every heart murmur or breathing issue is CHD. It's absolutely crucial to perform a differential diagnosis to objectively separate congenital heart disease from other severe cardiovascular and respiratory conditions. Physicians have to rule out things like rheumatic heart disease, cardiomyopathy, primary pulmonary hypertension, and in neonates, respiratory distress syndrome. Accurate diagnosis requires really careful clinical assessment because getting the patient on the correct treatment pathway from day one is literally a matter of life and death. Section 4, Investigation and Medical Management. Let's look at the diagnostic journey and the solutions. The diagnostic journey relies first and foremost on echocardiography. This is our most powerful diagnostic tool, giving us a detailed, real-time look at the cardiac structures and those abnormal blood flow patterns. Next up, a chest X-ray might be used to check for cardiomegaly, an enlarged heart, or abnormal vascular patterns in the lungs. Then, electrocardiography, or an ECG, is brought in to identify arrhythmias and chamber hypertrophy. And for the really complex cases, doctors will use cardiac catheterization. This is an advanced imaging technique used to directly measure intracardiac pressures and figure out precisely how that blood is flowing. Depending on the severity and specific type of the defect, management is highly tailored to the individual. Medical management is usually the first line of defense, using medications like diuretics and supportive therapies to control symptoms of heart failure. But to physically fix the defect, we have to move to interventional and surgical methods. Incredibly, some defects can now be treated using minimally invasive catheter-based procedures. Doctors can literally deploy a specialized device to close a septal defect without ever fully opening the chest. It's a massive leap forward. However, we have to acknowledge that many complex congenital heart defects still require open heart surgery to correct the anatomy, whether that means patching holes, repairing or replacing valves, or totally reconstructing major blood vessels. Section 5. Complications and patient prognosis. Let's talk about outcomes and long-term realities. When looking at the realities of CHD, the contrast is pretty sharp. Left untreated, the complications are devastating. We're talking about heart failure, pulmonary hypertension, a high risk of infective endocarditis, severe arrhythmias, and delayed physical development. It can lead to completely irreversible cardiovascular damage. But looking at the prognosis, it's highly variable and often incredibly optimistic. For mild defects, a patient might live a completely normal life with minimal to no intervention. For complex defects, obviously the journey is harder. It might require multiple surgeries throughout childhood and lifelong medical follow-up. But thanks to massive advances in pediatric cardiology and cardiac surgery, survival rates have improved phenomenally, rewriting the prognosis for thousands of children. Section 6. Strategies for Prevention and Protecting Fetal Development. So how do we get ahead of this? The foundational strategies for prevention rely entirely on optimizing maternal health and managing environmental exposures during that critical early window of embryogenesis. Ensuring adequate maternal nutrition is absolutely key. We're talking about confirming a rubella vaccination before pregnancy, strict management of maternal illnesses like diabetes, and the absolute avoidance of alcohol, harmful drugs, and toxins. Plus, for families with a known history of congenital heart defects, genetic counseling is a super vital step to understand the risks and prepare appropriately. As we wrap up this explainer, I want you to consider how early prenatal care is completely changing the game here. Early detection via fetal ultrasound screening allows doctors to spot many congenital heart abnormalities while the baby is still in the womb. This doesn't just prepare the parents emotionally, it gives medical teams the chance to completely revolutionize their approach, staging life-saving interventions for the exact moment that baby takes its first breath.